All right, group, we are just cruising along here. This brings us to Unit 14. Today we're going to talk about susceptibility testing and antibiotic therapy. Basically, we're going to talk about which antibiotics the doctor can use to treat certain infections. And this is probably the main focus of the microbiologist, is giving the doctor susceptibility results. Here we go. Let's go ahead and start by going over a few terms, and the first term I want to go over is MIC, which stands for minimal inhibitory concentration, and that's basically the lowest concentration of antibiotic that actually kills or inhibits the growth and reproduction of an infectious organism. MBC, on the other hand, is minimal bactericidal concentration. This is the lowest concentration of antibiotic that kills 99.9% of the inoculum. Then we have MLC, minimal lethal concentration, and that's actually the same as MBC, and it's a term that's kind of antiquated. Then we have disc diffusion. This is the diameter of inhibition of growth around a paper disc that's impregnated with an antibiotic. One method that we use for disc diffusion is called Kirby-Bauer disc diffusion method, which is a qualitative method to determine if an antibiotic or if an organism is sensitive, intermediate, or resistant to an antibiotic. Now, the MIC, getting an MIC is usually fine. Like I said, it doesn't kill any existing bug and limits reproduction and growth of that organism. It actually kind of encourages our own immune system to take up the slack. Now, the MBC value is valuable when an organism must be completely killed. So the MBC is actually very valuable when we're talking about antibiotics for people that are immunosuppressed. Other terms that you're going to want to be familiar with is bacteriostatic. Bacteriostatic doesn't kill any existing bug, but it is the term associated with the definition that an organism is inhibited from further growth and reproduction. So in other words, bacteriostatic doesn't kill any existing organism, but it limits growth and reproduction of a new organism. Bactericidal is when an organism is completely killed. So some antibiotics are termed bacteriostatic and other antibiotics are termed bactericidal. Antibiogram is the susceptibility pattern of an organism. I like to call it the fingerprint of a bug's susceptibility. For example, Stenotrophomonas is very resistant, and so if you look at its antibiogram, you would see that it's very resistant to most of the antibiotics. Antagonistic is when the effects of two antibiotics used in combination is actually less effective than using one separately. Antimicrobial levels refers to the concentration of antibiotics in serum. Generally, we aim for 4 times the MIC in serum for treatment. Serum bactericidal concentration is the dilution of an antibiotic in serum that kills 99.9% of the inoculum. Serum bacteriostatic concentration is the dilution of antibiotic in sera that inhibits the further growth or reproduction of the infecting agent. Synergy test is when we look at a couple antibiotics used together, and hopefully they are more beneficial to the host than they are independently. So synergy test is when you have multiple antibiotics when used in combination will actually be beneficial to the organism's destruction, more so than a single antibiotic given on its own. And then the break point is the antibiotic concentration that is achieved in body fluids for optimal therapy. So the break point is basically how concentrated antibiotic is in serum to be effective. And this is reported out as either sensitive, intermediate, or resistant. Sensitive means that the organism will not grow in the presence of the antibiotic. Intermediate means that the organism will grow with low concentrations of the antibiotic. And then finally, resistant means that our organism will grow in the presence of even high concentrations of the antibiotic. And finally, I promise this is the last list of terms for you. Antibodies are chemicals produced by an organism that inhibits the growth of organisms. This, of course, is made by your B cells, and they're also referred to as immunoglobulins. An antimicrobial agent is an agent active against microorganisms produced to target infectious organisms. This is also known as an antimicrobial. A chemotherapeutic agent is also known as an antibiotic of a chemical nature. This is an antimicrobial agent immune modulator, or anti-cancer drug. So typically when we're looking for antibiotic sensitivity or resistance, usually the MIC is enough. In some cases, the doctor may want the MBC. But in cases where a patient is immunosuppressed or if they have a life-threatening condition, the doctor may actually want the minimal bactericidal concentration, or the concentration of antibiotic that actually kills 99.9% of the inoculum. Usually the MIC is sufficient in adult patients who are not immunosuppressed. A useful antibiotic has the ability to destroy or inhibit many organisms, and this is called broad spectrum. A broad spectrum antibiotic is effective against not only gram-positive organisms, but also gram-negative organisms. A useful antibiotic will also prevent the development of resistant organisms. So we think that a useful antibiotic is a drug that won't easily convert Staph aureus to MRSA or Enterococcus to VRE. We want to make sure that our antibiotic does not produce any undesirable effects in our host. For example, we want to make sure our antibiotic doesn't produce allergic reactions or kidney or liver damage. Okay, and we also want to make sure that a good antibiotic doesn't eliminate the normal microbial flora of the host. We want to make sure that our antibiotics don't wipe out the normal flora and give rise to things such as Clostridioides difficile or yeast infections. Now, antibiotics are usually made from other biological life forms. So, for example, erythromycin is made from Streptomyces erythraceus. This is a fungus-like gram-positive rod. Penicillin is made from a mold known as Penicillium species, and our polymyxins are made from different species of bacillus. So just understand, most antibiotics are made from other biological life forms. Susceptibility testing is also known as sensitivity testing, and it's the most frequently encountered order in the clinical microbiology laboratory. In fact, in severe infections, doctors don't necessarily care about the name of the organism, but they do care about the sensitivity testing. There are several methods that we can use to determine an organism's susceptibility to certain antibiotics, and those types of testing methods would be called the Kirby-Bauer disc diffusion method, the microdilution method. One such example is the microscan system. We can do epsilometer tests, that's also known as E-testing. We can do modified Hodge testing, and also inducible clindamycin resistance tests like the D-test. And we'll talk about all these in upcoming slides. So there's a number of reasons why susceptibility testing is so important. You have to understand that the result may influence the doctor's choice of therapy. They may actually switch antibiotics based on our susceptibility report. The doctor can also use the results for ongoing quality control. Most organisms have a predictable antibiogram and can be used for internal QC. Communities can use susceptibility testing as an epidemiological marker when identifying similarities or differences between strains of bacteria. For example, if there's a salmonella outbreak, we can determine if everybody has the same strain of salmonella based on its susceptibility antibiogram. Now, there's a number of things that we have to consider when choosing the right antibiotic for our patient. We first want to consider the site of the infection. In other words, does our antibiotic have to cross the blood-brain barrier, or is it in synovial fluid? We have to consider the age of the patient. For example, fluoroquinolones and tetracycline are not good for kids. Fluoroquinolones can actually cause kidney and liver damage to people under the age of 18, and tetracycline can actually turn your teeth kind of a brown color, and that's why it's not good for developing bones of kids. We have to consider, is this a nosocomial infection or not? Is it a hospital-acquired? And if it's hospital-acquired, we may need prolonged treatment if the bug is resistant. What predisposing factors does the patient have? In other words, what's their immune status? Do they have some sort of underlying disease? What is the organism suspected of causing the infection? An organism of suspect can be treated faster with the appropriate drug. And then finally, what does the culture report indicate? Every 24 hours we run a culture report on different susceptibilities, and our doctor may switch antibiotics based on this culture report. There are definitely some dangers when using antibiotics incorrectly. For example, the population can become sensitized. So in other words, communities of people start to see more allergies to drugs or more resistant organisms to certain drugs. We can actually change the normal flora of the host or disrupt that normal flora. We can cause drug toxicity. Some drugs are nephrotoxic and they're toxic to the kidneys, and other drugs are hepatotoxic or toxic to the liver. And then finally, another problem with the indiscriminate use of antibiotics is you could develop more resistant strains. So there are certain times when susceptibility testing is appropriate. For example, if an organism does not show a predictable pattern against certain antibiotics. Now some do, like Streptococcus group A or Streptococcus pyogenes is always predictably sensitive to penicillin, so we would not need to test that organism for susceptibility testing. If our host is immunocompromised, we don't want to mess around with infections in these types of people, and so susceptibility testing would be appropriate. If there's a possibility that drug resistance is going to occur during therapy, then the susceptibility needs to be frequently monitored to watch that these organisms are not becoming more resistant. Now, when would susceptibility testing be inappropriate? If the infecting agent has a known susceptibility pattern, for example, Streptococcus A has a known susceptibility pattern to penicillin. It's always universally susceptible to penicillin, so we don't need to do susceptibility testing on Strep A. If the nature of the infection cannot be determined. If we can't determine which organism is the cause of the infection, then we can't do susceptibility testing. If our antimicrobial treatment does not accumulate at the site of infection, in other words, if levels are never high enough to get into the synovial fluid or cross the blood-brain barrier, then it is inappropriate to test susceptibility on those types of situations. Now, there are a number of reasons why antibiotic therapy could fail, and we're going to go over quite a long list here. If we have lack of information about the infecting agent, if we've never had a culture done, then the antibiotic that is prescribed by the doctor may not be effective. Then, of course, there's lab errors, including clerical errors. If you have a mixed infection or an infection with 2 or more organisms, this could cause antibiotic therapy to fail. If there's poor drug distribution, in other words, if the drug didn't cross the blood-brain barrier in certain types of infections, that could be a reason for antibiotic therapy failure. Drug interactions, including drugs that are antagonistic to one another. If you have an anatomic or mechanical failure, for example, if you have a necrotic tissue, and necrotic tissue can actually absorb certain concentrations of antimicrobials. If you have given the incorrect dosage of the antimicrobial, that's probably not going to take care of an infection. Incorrect route of administration, for example, antibiotics can be given orally or IV, intravenously. The wrong dosing interval based on renal clearance. You could be giving the wrong dosing interval. Maybe they're supposed to be taking it twice a day, once in the morning and once in the evening. And if you're doing that incorrectly, that can cause antibiotic therapy to fail. You could have what's known as a superinfection, where the organism is very resistant and not responding to the drug being given. You could have an incorrect antibiotic given in the first place. So you might have given a drug that's good for gram-positive cocci, but your patient may have a gram-negative rod infection. You could be on an insufficient duration of drug therapy, and that's pretty common. Your immune system can't help boost therapy in an immunological failure. And then finally, a misuse of antibiotics, not taking it until it's gone, or it may actually be a viral infection. So these are all reasons why antibiotic therapy could fail. There are many benefits to rapid and correctly doing susceptibility testing on your population. For example, the mortality rate starts to decrease, especially in cases of septicemia. The number of lab tests and imaging procedures actually decrease per hospitalized patient. The cost and length of stay is greatly reduced when you have correct and rapid susceptibility testing. The number of days the patient may be intubated is also decreased. The number of days that they are spent in an intensive care unit or an intermediate care unit can be decreased. And finally, the total cost of hospitalization decreases. And this is all because we've done correct susceptibility testing on our host. Now, antibiotics work in a number of different ways, and we're going to discuss all the different ways that antibiotics work. Antibiotics work by disrupting the cell wall, cytoplasmic membrane disruption, inhibition of protein synthesis, inhibition of essential metabolites, and finally interference with nucleic acid metabolism. And we'll talk about all of these, okay? But in cell wall disruption, the flow of nutrients in and out of the cell, the bacterial cell, doesn't work. In cytoplasmic membrane disruption, the enzymes that mediate transport of sugars are affected. In inhibition of protein synthesis, ribosomal protein levels are affected. In inhibition of essential metabolites, DNA synthesis is disrupted. And finally, when we see interference with nucleic acid metabolism, those nucleic acid metabolism changes, and that disrupts DNA and RNA synthesis. So let's go ahead and take a look at all of these different modes of actions. So this slide discusses mode 1 and mode 2 when it comes to antibiotic modes of action, okay? And that would include cell wall disruption and cytoplasmic membrane disruption, okay? Our gram-negative bacteria have an inner and outer membrane. The most simple way to deliver antimicrobials is by direct diffusion across that membrane, okay? For most gram-positive organisms, the antibiotic easily transfers across the membrane into the organism, but some antibiotics will interfere with the formation of cell walls by altering the sugars that form peptidoglycan. Okay? Mode number 3 would be inhibition of protein synthesis. Antibiotics here are designed to inhibit protein synthesis, and that will interfere with an organism's ability to have peptidoglycan chain elongation. And then modes 4 and 5 would include inhibition of the essential metabolites and interference with nucleic acid formation. So some antibiotics target the essential metabolites, limiting them from getting into the organism, and then the organism dies. And some antibiotics interfere with the formation of nucleic acids, and these types of antibiotics interfere with the genetic makeup of the organism. So here we have a list of antibiotics that are either bacteriostatic or bactericidal. Remember, the bacteriostatic drugs are the ones that actually inhibit growth and reproduction of the organism, while the bactericidal drugs are the ones that actually kill all existing organism. The bacteriostatic antimicrobials are chloramphenicol, erythromycin, clindamycin, sulfonamides, trimethoprim, and tetracyclines. The bactericidal drugs are the aminoglycosides, vancomycin, the quinolones, rifampin, metronidazole, the beta-lactams, and the penicillins. There's several different methods for susceptibility testing. One such method is called the microdilution assay. This is where we can find MICs and MBCs through a machine called the microscan, which is a quantitative way of determining if we have an organism that is sensitive, intermediate, or resistant to a drug. In the microscan method, or the microdilution assay, we're actually doing serial dilutions of different concentrations of antibiotic. In the disc diffusion method, this is also known as the Kirby-Bauer method, we are looking for a qualitative result. We want to know if our bug is sensitive, intermediate, or resistant to antibiotics, but it doesn't actually give you a number. In the microdilution assay, it's a quantitative assay. In disc diffusion, it's a qualitative assay. We also have gradient diffusion tests. This is a quantitative test known as the epsilometer test or the E-test. This is another susceptibility testing procedure. We also have serum bactericidal titers, and finally synergy tests. So let's talk about some of these. In the Kirby-Bauer test, basically what we have are antibiotics that are impregnated in little paper discs. What we can do is we can take a 0.5 McFarland standard of our organism in some sort of nutrient broth, and we can make a lawn of that on a large Mueller-Hinton plate. Okay, and then we can incubate the plate, and at the end of our incubation period, we can take a look at the different zone sizes. Zone sizes that are typically large mean that the bug is sensitive to that drug, and zone sizes that are very, very small usually means that our bug is resistant to those drugs. There are some advantages to the Kirby-Bauer disc diffusion method, and again, this is a qualitative test where we're just looking for sensitive, intermediate, or resistant to certain drugs. Okay? Advantages of the Kirby-Bauer test is that it's flexible and simple to set up. It's technically simple to interpret, and it may be modified for testing more fastidious organisms. And what I mean by that is typically the media of choice for doing Kirby-Bauer is called Mueller-Hinton agar. But if you're testing a bug like Haemophilus or Neisseria, you could buy Mueller-Hinton with chocolate in the media, or you could buy Mueller-Hinton with blood in the media. So it's very modifiable. Some disadvantages of the Kirby-Bauer test is that it's not quantitative. We don't get an actual number in terms of concentration of antibiotic. Instead, we just get sensitive, intermediate, or resistant. Another disadvantage is it is not a good procedure for slow-growing organisms. We do want to look at our Kirby-Bauer at about 16 to 20 hours. And not all antibiotics diffuse from the paper discs very well. So to do the Kirby-Bauer disc diffusion test, you need a couple of supplies. You need a Mueller-Hinton agar, and again, that's going to be plain or combined with blood or chocolate. You're going to need a nutrient broth, the antibiotic discs, your inoculum, which is your bug, an incubator, and calipers. Now, whenever we're doing susceptibility testing, we want the procedure to be standardized. We want to make sure that the pH of our plate is standardized at about 7.2 to 7.4, and that's our Mueller-Hinton agar. We want to make sure that our Mueller-Hinton agar provides certain cations like calcium and magnesium. We want to make sure that our incubator is set at 35 degrees Celsius. We want to make sure that we have our inoculum in broth, and then that broth is set to be a 0.5 McFarland standard. We want the proper amount of media in the plate. Usually we use the big plates, and we want about 60 to 80 mils of agar at a depth of about 4 millimeters. And then we want our antibiotic discs. And these are usually frozen until we're ready to use them, and our working supply is refrigerated. So here's the procedure for the Kirby-Bauer disc diffusion test. We're going to make a 0.5 McFarland standard of our organism in a broth. Okay, and what you can do is you can either grow your organism in that broth until it is a 0.5 McFarland standard, or you can just go ahead and make your 0.5 McFarland standard from your plate directly. Then we're going to use this sterile cotton swab, dip it into the broth and wring out the excess, and we're going to use a lawn formation technique, streaking the swab 3 times in 3 different directions all the way across the plate. Using a disc dispenser or disc shooter, we're going to apply all of our antibiotic discs to the agar surface. Okay, and the discs must be a minimum of 15 millimeters apart, so we're able to read the zone sizes. We incubate our plate for 16 to 20 hours at 35 degrees Celsius, and then we use calipers to measure the zone sizes. Now keep in mind, if you have a proteus and it starts to swarm, we ignore that swarm. Okay. We also want to ignore any slight growth around the sulfa drugs, and we want to be aware of mutants, which are colonies growing inside of the zone of inhibition. So here's a picture of what the Kirby-Bauer disc diffusion test looks like. So what we've done is we've made a lawn of our bug, and then we've incubated it with the antibiotic discs on the agar. So those zone sizes, we would measure them using calipers, and then we would take a package insert and we would evaluate whether or not the zone sizes mean that it is sensitive, intermediate, or resistant to that antibiotic. There is some quality control that we need to do for the Kirby-Bauer test. So if we are running a Staphylococcus, if our unknown organism is a Staphylococcus, then we also need to run Staph aureus ATCC 29213 as our control organism. Okay, ATCC stands for American Type Culture Collection, and it is a quality control organism that you can purchase. If we are testing an enteric, then the organism we want to run in addition to our unknown enteric is E. coli 25922. If we are testing a streptococcus, then we would run our Enterococcus faecalis 29212. And if we were testing a non-fermenter, then we want to run at the same time Pseudomonas aeruginosa 27853. You don't need to know those ATCC numbers. Now, microdilution is another way we can test for susceptibility, and this is a quantitative procedure where we can actually give the doctor a number. Okay, here we have a series of microtube wells that are molded into a plastic plate. There are dilutions of the antimicrobial agents in each well, so there's a certain concentration of antibiotic in each well. Generally, organisms that grow in each well are considered resistant to that concentration of drug. Organisms that do not grow in the presence of the drug are considered sensitive. Organisms that grow in the presence of low concentrations of drugs but will not grow in the presence of high concentration of drugs are considered intermediate. There's some advantages to microdilution, and there's some also disadvantages. Some advantages is that it's quantitative and it's not influenced by the organism's rate of growth. So in other words, it's okay for anaerobes and slow growers. Some disadvantages is that clinicians cannot interpret the numbers very well, and so we have to make an interpretation for them as to whether our organism is sensitive, intermediate, or resistant to a drug. It is an expensive technique, and it's also technique sensitive. You have to know what you're doing in order to not make mistakes. So let's take a look at the microscan susceptibility test. What we're going to do is make a 0.5 McFarland standard of our organism in a 3 ml water. Then we're going to take an MLA pipette using a sterile tip, and we're going to transfer 100 microliters into a 25 ml inoculum water. We gently resuspend that 7 times by inversion and then pour that into what's known as a seed tray. Okay. After we pour it in the seed tray, we use an instrument known as the Renock, which is a multiple well pipetting tool. And we take that Renock and we actually aspirate our sample and then pipette it into our microscan panel. Okay. We oil the panel anywhere that it has a test analyte that is underlined, and then we label the panel and cover it aseptically with a lid. We incubate that for up to 24 hours, and then we view our wells for growth and interpret the MIC. So let me show you a picture of the microscan plate on the next slide. So in this circumstance, we've got clindamycin, penicillin, and erythromycin in each row here. So if you look at clindamycin in the first row, you can see that all of the wells are growing in the entire first well row from A1 to A12. So that means that our bug is resistant to clindamycin. Our MIC would be greater than 32 in this situation. If you look down at penicillin, okay, it's growing in the first 3 wells of the row, but it's not growing in the 4th through 12th well. So our stopping point would be an MIC of 0.06 micrograms per mil, and that would be a circumstance where our bug is intermediate to penicillin. And erythromycin is the same way. You can see that it has a concentration of 8 micrograms per mil, and that would be intermediate to erythromycin. This will make a lot more sense when we actually do it in lab. Now, there are times where you're going to want to use microdilution instead of disdiffusion. It just sort of depends. But when you have dosage and serum levels that need to be monitored for some reason, then it's important to do microdilution instead of disdiffusion. Okay. If you have a slow growing or anaerobic organism, we need to do an MIC using microdilution. When diffusion test yields questionable results, so if you get a weird result on your Kirby-Bauer disdiffusion test, then instead you can do microdilution. Okay. When you have to have a precise level of antibiotic for your patient, then it's important to do microdilution. If you want to determine bactericidal activity, and again we want to use microdilution. And then finally, if you want to determine synergistic or antistic properties of two drug combinations put together, then you'd want to do microdilution instead of disdiffusion. Okay, so the two different types of susceptibility testing that we talked about today is Kirby-Bauer disdiffusion and microscan microdilution.